Hi guys, hope you're well, and today we're going to be talking before your class starts about suicidal ideation and everything that we learn about from research and in good clinical practice on how to help somebody. This course on crisis and trauma is a sobering course, and I want to make sure, just a little aside here, that you guys don't get locked into compassion fatigue. Compassion fatigue is well researched. Physicians have it, parents have it, therapists have it, pastors have it. When you see these, just how difficult people's pain can be, and then you tend to burn out, and then you're no good to anybody else. So make sure, not only just this course, but your entire time with us, that you've got good support around you, you're taking care of yourself, you're eating right, you're sleeping right. I know we make you read too much, but you still got to sleep. That you got a healthy church and people around you, because these are where the pain is, and you got to be strong enough to handle the pain. So I want to talk to you about when you have a suicidal ideation in your client. Now, suicidal ideation, there's a difference between ideation, intent, and an activity. Ideation means it's just in their mind. Intent means they have a plan and they're going to go more than just think about it. And then in activities, when they actually have an event, a suicidal event. So this is kind of that first stage. So far in the assessment research, we hope this changes, but right now there is no screening tool that exists which accurately predicts an attempt. Just want you to know that. Maybe there will be, but you can't go buy something and say, take this and see if we can predict it. It's just not there yet. There's so many variables of suicidality. Also, the strongest predictive factor that we found is a previous attempt. So if a person has it in their history on an actuarial level, their likelihood that it will happen again is higher than a person who has no attempts. So just be aware of that. That's why your history is so important, guys, to make sure you know these things. You don't want to ever be taken by surprise on this. Now, there are a couple of kinds of suicidal ideation. One is active and one is passive. And passive, it's sort of like when somebody thinks, I'm just better off if I wasn't here. I'm taking up too much space here, or I've failed so much, or I'm down on myself, or I've lost an important relationship, or I've not done well in career, or whatever. And that's just sort of that, it'd be better if I wasn't here. Now, that's certainly a yellow flag. It could be a red flag, but it's at least yellow, but it's not nearly as severe as, some kind of a plan and moving beyond that. Active suicidal ideation is when they don't have a plan in mind yet, but they're thinking about a plan. What's the method? What's the motive? Am I going to shoot myself, take drugs, hang myself, take my car off a ridge, or whatever? That certainly would be more severe, and you've got to find that out. Is it more passive or more active? A lot of people in psychotherapy will go through passive suicidal ideation because you get to some early pain, something with mom or dad, or just the way you feel about yourself, and you think, this life kind of sucks. It might be better if I wasn't here. And that's something you've got to pay attention to and make sure you're listening to. But most people, as they get connected and get attuned to, and they find that they're understood and they're not alone, they find God, it goes away. I'm never dismissing it's important, but relatively to the other things, it's less important. Always, always, always determine danger to self. And what I mean by that is, one of our jobs here to teach you, for you to continue in, is to see how much of a red flag this is. So when you're hearing, I'm going to give you some examples of that. When you're hearing the content, whether it's manifest content or latent content. Now, manifest content is, they sit down, they say, I've been thinking about hurting myself, shouldn't be here. Latent content is when you hear it sort of in the words between the words, something like, so now I was talking to Susie and she's got such a great life, and I don't know, she's going to have a full life, but I just never know. Well, that would be, if you're really listening with that third ear, you're going, she's comparing herself to a successful person, and then she keeps saying, I don't know. That's not manifest content. I'm going to hurt myself. I'm thinking about it. But I would pay attention to that. So what do you mean you don't know? That's what good therapists do. They go to the words without words. And ask them directly if they're planning to hurt themselves. That's a very important, legitimate psychotherapeutic intervention. It seems like from one of the things you're saying, are you planning to hurt yourself? And so don't fragilize them and don't tiptoe around it. It's often a relief to your client. Because now they can process it. But it's not only a relief to them, it's responsible for you to do it. Get the history. I talked about the history earlier. And make sure, hopefully a good Townsend Institute therapist is going to have the history at the first session, the first two sessions anyway, so this is not new information for you. But if you don't have it, if you're inheriting that person from somebody else, you make sure you get their history of their life, and use your diagnostics. And the diagnostics are always mood, thought, and behavior. What's the mood? You know, depression, anxiety, hopelessness, helplessness, you know, guilt, shame, those kind of negative emotions. Thought is the cognitive pieces of I'm not worth anything, there is no good future. And then behavior, I've been doing some risky behaviors. Get collaborating information from any other sources. If you have the ability to, it really helps to either have, if you have access to people in their lives or people in their experience that they give you permission to, other clinicians they might have seen, or a psychiatrist or pastor or whatever, if you can get them to sign off on their release of information, which some clients will and some clients won't. But the more information you have from other sources, the better. Stay in contact with your clinical supervisor. You know, when you go on internship before you get licensed, and after you graduate from us, you'll be getting more hours before you get licensed. Clinical supervisor's there for that, and just stay in contact. When you've got somebody who has suicidal ideation, they should always be a matter of, you got to bring up what they're doing every session that you have with your clinical supervisor. That's top of the list. And then when in doubt, treat the person as a risk. If you don't know, treat them as a risk. What does that mean? Well, that means there are protocols, and protocols that your organization or private practice has, anything from calling 911 to making sure they don't leave the room in some cases, and there's different protocols, or I mean, sometimes having somebody else in the room with you, go out in your practice and grab somebody in and say, if this person says, I can't promise that I'm not going to hurt myself, they stay in your room until 911 comes. Those protocols are entrenched in every good organization. Make sure you know them. So serious stuff, but you can really help. All right, have a good class.